And thank you for joining us for this evening's lecture. We are going to record it, so if you have your camera on and you don't want to have your camera on, then please do switch it off, but by all means keep it on if you are happy to have it on. I'd like to welcome Mr. Henry Ferguson, who is our speaker tonight on diverticular disease. Thank you for joining us this evening. As I say, we are recording it and we will send the recording out to you and the slides as well, so you don't need to furiously be taking notes. Just a few bits of housekeeping to run through as we do each time. Could you move on to the next slide, please? Please, could you pop yourselves on mute? But if you do have any questions, you're very welcome to either put it in the chat function and either Vicky or myself will read it out on your behalf, or Mr. Ferguson is quite happy to be interrupted. You can pop your hand up, you can ask him a question if you want to, and if you type it into the chat function, I will also interrupt and ask the question for you. We will be at the end of the session having a link to the feedback, and I know I say it every time, it's just really, really useful for the consultant and also for us to know how you felt the lecture went and if there are any other topics that you would like to hear about. But anyway, you didn't come to hear me talking, so I will hand you over now to Mr. Ferguson. He has recently joined us, but he is now going to tell you a bit more about himself, as well as talking to you about diverticular disease. Over to you.
Thank you very much, Mel. And thanks everyone for tuning in your evening. First, a bit of an apology. I've had that horrible cold that apparently isn't COVID, but it feels like COVID. So if I lose my voice in the middle of it, I apologise. Now, a little bit about me. I graduated, nearly 20 years ago now from what's now Cardiff University, but was the University of Wales College of Medicine, and did my foundation training down in South Wales at the Heath Hospital in Cardiff, and then in Newport in South Wales, where I got a nice sort of taste for surgery and wanted to make a career out of it, and was fortunate enough to get a core surgical training post and then a higher surgical training post within the West Midlands, which was good because that's where my now wife had got a core medical training job, so that made life a little bit easier. I started that back in 2009, and then as part of that I did an MD at the University of Birmingham, which was an interesting basic science degree actually. I had no background in that, but it was looking at vaccine treatment for colorectal cancer, which I can bore you for hours about, but not tonight. I ended up being the president of the Duke's Club, which is the National Training Association for colorectal surgery, and I've made a lot of national and international contacts, which I value tremendously from that. And before starting my consultant post in Warwick, I went on a travelling fellowship to Mount Sinai Hospital in Toronto to widen my experience of complex inflammatory bowel disease surgery, which to a certain degree is where a lot of my passion lies. I then got appointed to Swift in 2018 and have been working hard there ever since, building up my NHS practice and getting to the point where I feel like I can now offer a sensible private opinion. As I think before that, probably I'd just have been chancing it. So in my NHS practice, I do general surgery and colorectal surgery. I'm a minimally invasive surgeon, and I've been leading the introduction of robotic surgery into Warwick Hospital over the last year. We actually started operating in May, and hopefully some of you have had some patients come through. We've done 20 major resections and a selection of minor robotic operations now, so it's all getting going. My predominant caseload is colorectal cancer and inflammatory bowel disease, but I do have a side angle in complex abdominal wall repair, parastomal hernias, and then when I have time I manage to get some routine general surgery done. Alongside that, I love training, I love teaching, and I'm a recognised postgraduate tutor, and I look after the medical students from Warwick University and also teach the Buckingham medical students as well. And when I've got time as well, I'm also a local primary investigator for some of the surgical clinical trials that are running. Our latest one's about quality of life with parastomal hernias, if you've got any patients who are interested. So that's enough about me, obviously. The aims of today are to really go through diverticular disease, go through the terminology that's used, because there's a little bit of inconsistency in that, even within secondary care. Look at how we can all help our patients, and then if we've got time and you guys haven't fallen asleep, some case studies at the end just to illustrate my points. So I guess let's start simple. So a diverticulum is an outpouching from any organ, really, but diverticuli, as we consider them in the colon, are actually false diverticuli because they aren't all layers of the bowel. They're just the mucosa that's pouching through the muscle. So they're very fragile, and that is the root of why there's such trouble. So why does it happen? As I say, everyone loves physics and anatomy. So the bowel is designed to squeeze. It wants to push against something and propel stool through it. That's its job. And in order to do that, it likes fibre. When the bowel contracts, it transmits a significant radial force, and it needs to act on a bulky stool. Because of conservation of energy, if there isn't a bulky stool, the force needs to go somewhere else. And it tends to go for the weakest part of the bowel. And as you can see here, where you get a perforating vessel running through the muscular layer of the bowel, that's an innate weakness. So you tend to get blowouts, or these diverticuli, where the perforating vessels occur, which is an explanation as to why they have a propensity for bleeding as well. And so a little bit about the terminology. So a lot of people, particularly the public, use some of these, all of these, completely interchangeably, but there is a definite progression of seriousness and definite terminology that we really ought to be getting right. So I'm going to talk a bit about diverticulosis, diverticular disease, diverticulitis, and then complicated diverticulitis. So diverticulosis, that's having diverticuli. Whether you've got trouble or not, if they're there, you have diverticulosis. And there's a very high prevalence over the age of 50 in the UK, almost universal by the age of 80. Beyond that, we've got diverticular disease, which is essentially symptomatic diverticulosis. So any symptom you can ascribe to your diverticulosis would count as a disease. It's a condition that affects our patients. So generally, left iliac fossa pain, erratic bowel habit, maybe some bleeding, but nothing more significant than that. Big crossover there with irritable bowel syndrome, and sometimes those symptoms can be very difficult to pick apart. The progression beyond that is diverticulitis, which, as the name implies, there is inflammation, or maybe infection, but mainly inflammation within the diverticuli. Okay, so as a progression from diverticular disease, there's maybe clinical evidence of inflammation. So patient might have a fever or be tachycardic or have some abdominal peritonism, or the bowel really only has a couple of ways of being unhappy, and one is to spasm and the other is to produce mucus. So patients may produce mucus in this setting. And then obviously a bit more relevant to secondary care, where we can get bloods back very quickly and easily, but even in primary care, a raised white count and CRP on the background of symptoms consistent with diverticular disease is more convincing of diverticulitis. Then what we tend to see more in secondary care would be the complicated diverticulitis. So this is a progression from simple inflammation of the diverticulum to it rupturing. And we can either have a free rupture, so a free perforation, or it can be a contained problem where there's an abscess next to the bowel, or sometimes it can be almost a silent abscess that sits on top of the bladder or sits on top of a fallopian tube or even the uterus, and then gradually erodes through and creates a fistula. but the pathophysiology is all stemming from the perforation of a diverticulum. So, risk factors. There are certain things we can do something about, certain things we can't. So I can't do much about age, unfortunately. I can't do much about gender, but slightly more common in women and definitely gets more common as you get older. Things that patients and people in general can do to hopefully avoid getting diverticular disease in the first place, and not to smoke, because smoking destroys your connective tissue. So hence the association between smoking and diverticular disease, smoking and hernias, smoking and aneurysms. It's all due to collagen injury. Obese patients are more prone to have diverticular disease, whether it's a direct causation or whether it's associated with having a less healthy diet, which is lower in fiber or ultra processed food, is difficult to pick apart. But certainly obese patients are more likely to have troublesome diverticular disease. And then we need to think, how do we make a diagnosis? I'm obviously very blessed at being in a secondary care hospital where I can just get a CT, I can do an endoscopy, and I know you guys are much more skilled diagnosticians than me in that regard, and most of the diagnoses you'll make of diverticular disease are likely to be clinical. But there are other conditions which cross over with the symptoms, and certainly before we'd be wanting to think of any significant invasive treatment, we'd want to have a proper diagnosis. And so we would want to be thinking about gaining either a CT scan or an endoscopy to confirm that. Is there a role for probiotics in diverticular disease? I see it's popped up. It's a difficult one. I think not as a primary issue, I would say, but the issue, if someone has been on repeated courses of antibiotics and is getting a lot of erratic bowels because of that, then there certainly could be a role there. I'm not aware of any evidence for taking probiotics and preventing recurrent attacks of diverticulitis. But thank you for the question. So first line management for all of us would be health promotion. So getting people to stop smoking, desperately trying to increase dietary fiber. This is a definite problem in the UK. It's remarkably difficult to find proper unrefined fiber. It's the best thing to do is think what makes you poo and recommend it to your patients. Okay, you just want to be eating brown bread. There's a lot of information out there about avoiding seeds and things. Actually, there's no evidence that eating seeds predisposes you to having diverticular complications, and in fact the seeds themselves can act as a good source of fiber, so I certainly wouldn't be excluding those. And certainly the patients need to increase their fluid intake, because being constipated and having firm stools increase the amount of spasm and force that the bowel puts through. So good basic bowel advice there. And then really the crux of how you manage these patients should be to decide whether this is symptomatic diverticular disease or whether there is definite evidence of inflammation or infection in the patient, because the management is completely different. So first line management for symptomatic diverticular disease, actually, if it's really flaring, if we'll call it a flare, if the symptoms are bad, a lot of those symptoms are related to bowel spasm, and continually forcing fiber in at that point actually gives your bowel too much to do. So I tend to recommend that when patients experience a symptomatic flare with their diverticular disease, that they actually go low residue, so avoid fiber, just to rest the bowel a bit. Some patients even prefer to go onto a full liquid diet at that stage for the same reason. I would recommend simple analgesia, paracetamol, non-steroidals, but really try and avoid even simple opiates, because they're so constipating, and it tends to run into a problem with potentiating smooth muscle spasm. So opiates have a I don't want to preach to the converted. Your pharmacology may well be better than mine, but one of the actions of opiates is actually to cause smooth muscle contraction. So particularly for colicky, bowel pain, biliary pain, actually sometimes opiates are not the best thing. Once the flare has settled down, it's a good idea to introduce a stool bulking agent to make up for the fact that getting hold of proper fibre is difficult. Fibergel being the most commonly available proprietary brand, or anything with Iscabagula husk is good. Some patients will find that bulks their stool but doesn't make them go enough. So in addition to that, I'd introduce a macrogol. So Cosmocol, Laxido, Movicol, they're all the same thing, as you know. But that combination of a bulking agent and an osmotic laxative can be very efficient in this setting. I would avoid stimulants for the same reason as avoiding high fibre when the bowel's irritated. So things like Senna and Bisocodyl, even sodium docusate, are primarily stimulants. And if your main problem is that you're getting symptoms from bowel spasm, it's only going to make it worse. So I try and hold those back. When do you give antibiotics? So if you've got symptomatic diverticular disease, absolutely no benefit. There's no benefit because there's no infection. It won't do anything. It'll just put them at risk of C. diff. Interestingly, and this is something we still struggle with in secondary care as well, is that actually there's no good evidence of benefit from antibiotics even in simple diverticulitis with a raised CRP. There's no evidence that giving antibiotics decreases complications or decreases the length of time that you have the attack, which I find difficult to understand and difficult to believe. But if we're going purely evidence-based, maybe we shouldn't be giving antibiotics. Maybe we should just be giving anti-inflammatory medications and supporting the patient. And then, from your point of view, when should you be referring these patients? So I would say that you're going to have two scenarios for these. So the first would be as an emergency, you're concerned this patient has peritonism and they need to be seen because we're worried that they might have a perforation, complicated diverticulitis, and require the input of secondary care. And we're always very happy to receive these referrals. More electively, the indications are a bit more varied. So patients may have recurrent simple diverticulitis. They may just have difficult symptoms related to diverticular spasm, symptomatic diverticular disease, or it may be that there is diagnostic uncertainty. There's obviously a lot of worry amongst patients, particularly with Deborah James, that even from a young age that bowel cancer can be about. And a lot of patients are not reassured by a simple nod from their doctor saying it's okay, it's probably diverticular disease. So we're always happy again to receive referrals to ease over any diagnostic uncertainty and offer investigations from that point of view. From an emergency point of view, this is often what we see. And I appreciate you probably don't spend as much time looking at CT scans as I do. But this on the left of your screen is a diverticular abscess. And then on the right, there's evidence of free gas within the abdomen at the front here. And these are obviously situations where you need to be in hospital if you're a patient. Now, in case you wonder why we do the things we do in secondary care, I'll give you a quick rundown with these. So an abscess, generally you'd think, well, it needs draining. Now, the overall evidence is that actually if an abscess is less than 5 centimetres, it should settle conservatively with intravenous antibiotics. Above 5 centimetres, there's less of a chance of that happening. So we're more inclined to want to think about radiological drainage, or in the worst or the more serious situation, surgical drainage. Obviously, that needs to be balanced against the underlying health of the patient and their wishes. Free perforation is more difficult. Free perforation is very serious, particularly if there's fecal contamination, and it's uncommon to be able to get away with free perforation unless the patient is very, very stable with it. So once we get referrals for that, we're really thinking about emergency surgery. And I'm sure all of you have had the joys of a surgical house show at some point and seen these poor patients after an emergency Hartmann's procedure. It is always a balance of risks and benefits, and a lot of particularly elderly or very comorbid patients just do not do well with or without surgery, and it's a terrible situation to be in. But the main indications are gross fecal or purulent contamination, or septic shock that's refractory to simple measures, and a non-salvageable situation without an operation. But as you can see, the mortality rate is significant for all comers, and morbidity, particularly with having usually an end colostomy, having fecal contamination into the wound, incisional hernias and ongoing problems from that point of view, is significant when we're dealing with these in an emergency setting. So we really don't want to be dealing with patients as an emergency if we can avoid it. See, as we see here, it's a big cut, end up with a big scar, colostomy, and obviously patients don't like that. There's significant knock-on consequence to health economics, particularly in terms of stoma appliances. So we much prefer, if we can, to pursue elective surgery. And while all of these indications are relative, the things which we would consider surgery for, or I personally would consider surgery for, would be someone who's got away with complicated diverticulitis. So some patients will either have a radiologically drained abscess or an abscess treated with antibiotics, and they may not wish to have that again, in which case we would offer a sigmoid colectomy in that situation. But it's not, as the Americans would say, a definite indication. America is very, very keen to offer surgery even after a single episode of complicated diverticulitis. But as you can imagine, the sequelae of such major surgery is significant. So a proper conversation in this situation is always important. Some patients with recurrent simple diverticulitis might want a sigmoid colectomy. When I'm talking to these patients, it's very important for them to understand the significance of an operation. You know, often they come in and go, well, you can just whip it out, can't you, doc? And you're like, well, kind of. But obviously, as you're aware, it comes with the significant possibility of an inpatient hospital stay, having to make an anastomosis in the joint, and then the potential for an anastomotic leak in that situation. And a lot of patients still, even in an elective way, don't get away with either a temporary, without a temporary or a permanent stoma. But patients are very, very welcome to come and have that opinion. Symptomatic diverticular disease is very difficult, and all of my colleagues and myself have all ended up in a situation where we've done colectomies for diverticular disease, and you get the specimen out and it's really not that impressive, and you just cross your fingers and hope that their symptoms are going to get better. But as I alluded to, there's a lot of overlay with functional bowel spasm and irritable bowel syndrome, and unfortunately some patients with purely symptomatic diverticular disease can derive no benefit from a sigmoid colectomy. Obviously, the benefits of having your elective surgery is that you get me or one of my colleagues to do your surgery. We're experienced. We do this regularly. We offer minimally invasive surgery as standard. I personally currently am offering robotic surgery as standard, or laparoscopy if I can't get my hands on the robot that day. But I like doing robotics, and I'll bore you with a video of that in a bit. There's a good chance of avoiding a stoma in appropriate patients. So providing the patients are well optimized, works up appropriately, don't have active infection, have stopped smoking, then most will avoid a stoma. Okay, the reasons for giving them a stoma electively would either be that they don't wish to risk an anastomosis, or that the joint would be so low down that they would get poor function, or that in the situation where you might give them a temporary ileostomy if they're very high risk for an anastomotic leak. So smokers, the very elderly, known arteriopaths, or patients who do have a bit of grumbling sepsis, I might consider that. And as you can see, the mortality rate is much, much lower than the 12% in emergency surgery, and the significant morbidity, again, is much lower, mostly owing to the fact that patients have minimally invasive surgery. So this is a patient I've done within the last few months. So that's me on my robot. And that's in the middle picture is my patient. That was day 2 after his major surgery. I was just walking down the corridor to go and see him, and he was striding off to get his coffee from the coffee shop. And so clearly, this kind of surgery is a mile away from having a big slash down the middle of your tummy and a colostomy. And as you can see, his cuts on the right hand side. That was 2 weeks post-operatively. He was fully back to all of his baseline essentially. So I'm very pleased with the robot, and I'm going to bore you with a video of it. So I suspect most of you have not seen robotic surgery before. So the difference here really is that while it looks like standard laparoscopic surgery, the instruments have wrists, so you can get round angles, and it's much more like having a little pair of hands. And instead of relying upon, I see Verda Amins on the call, used to be one of my trainees. She's very used to holding the camera for me. But with the robot, you control the camera yourself. So I'm controlling in this operation. I'm controlling the camera. I'm controlling 3 operating arms, so I get optimal retraction, a stable view. When I'm doing this surgery, it's in 3D, it's in HD, it's beautiful. And as you can imagine, and as you can see from the video, you barely spill a drop of blood if you're in the right plane. And this is an inflamed colon. And even with standard laparoscopic surgery, the dissection is not as nice as this. And you can see here, as I say, I'm going to bore you to death if I show you too much of this. It's only a couple of minutes long, but as you can see, the wrists of the instruments are soft and gentle, and I think it's a real key change in how we're going to treat patients. And robotic surgery is applicable to major bowel surgery, but also applicable to hernias and beyond. So watch this space. As I say, it's a very exciting time for me at Warwick from this point of view. And obviously, if you refer me a patient at the Nuffield and it requires this kind of surgery, I can offer this. I can offer robotics where others can't. So I'd be very happy to receive the referrals for this kind of thing. Let me skip that, as I'm sure you're not as interested as I am in it. So let me take you through a couple of cases. This 40-year-old lady, apologies, was admitted as an emergency. She came in. She had extensive cosmetic surgery and abdominoplasty, breast implants. She was very image conscious, and she came in with a history which, for all the world, sounded like ureteric colic, including microscopic hematuria. She had normal bloods, and obviously we thought, well, never mind, send her for a CT-KUB, and unfortunately that confirmed that she had quite significant diverticular disease, with evidence of free gas over the liver. As you can imagine, she wasn't particularly impressed to be told that she might need an emergency operation. She might need a colostomy. So despite the fact that she had a perforation, we managed to conservatively, and her small pelvic abscess resolved. 3 weeks later, she came back in with another perforation, very similar presentation, again, point blank refused surgery. But this time had the fortune to come in under me. So I was able to arrange an expedited robotic sigmoidolectomy. She ended up with a 2-day hospital stay, no stoma, and she's been very pleased with the outcome. The second case is a little bit more of a learning one. So she was 65. She was, I think, a head teacher with known diverticulosis. She'd had this historic diagnosis of diverticulosis, I think made on a scan for something else many years ago. And she'd been coming to see her GP with recurrent episodes of abdominal pain, which were left iliac fossa, consistent with diverticular disease, and loose stools. And I'm very pleased to say that the GP had sent a fit test and this was negative, so there was some confidence there that she didn't require referral via the 2-week wait route. She had multiple courses of community oral antibiotics, but was not settling down, so has referred to me to consider surgery. Now, when I looked into things, she did have some symptoms which were consistent with diverticular disease, symptomatic diverticular disease, maybe even diverticulitis. She'd had some shakes and shivers. But she did have a documented history of irritable bowel syndrome going back some 30, 40 years, and the overlay is quite significant in a lot of patients. I went through and looked through her previous biochemistry, and there was a minor CRP and white count rise, somewhere in the order of 40, 50, something like that. So there's definitely something going on. And I reviewed her previous CT scan from many years ago, and yeah, there was diverticular disease. So I thought possibly that's what it is. But given that her symptoms were annoying but not debilitating, we recommended the conservative measures I'd previously considered and got a flexible sigmoidoscopy. Unfortunately, she did definitely have a significant diverticular segment, significant enough to be causing the symptoms which she was having. But she also had pseudomembranous colitis and a positive culture for C. diff. And so I was in a difficult situation, that she was probably getting recurrent diverticulitis, but she had an infected colon. So that resulted in quite a long discussion and a couple of clinic appointments. And during that time, we treated her C. diff and said, let's try and avoid oral antibiotics, because I wasn't 100% sure that she was getting recurrent diverticulitis. But she was getting ongoing symptoms and she was really, really keen for surgery. And then I did a laparoscopic sigmoid colectomy, pre-robot, and she actually did very well. She was home in 3 days, no stoma, happy patient, but she's still got the pain. She's still got the same pain as before. I've scoped her again, she's got no problems with her anastomosis, and I suspect that probably the pains that she was getting previously was irritable bowel syndrome. And obviously, while she's had a positive outcome, actually, with retrospect, we've put her through significant abdominal surgery for very little in the way of benefit. I think a couple of lessons really: just be careful about giving antibiotics without definite evidence that they've got diverticulitis. And also, from my point of view, the learning point was don't be swayed too quickly by the patient. Realistically, I think the fact that she was getting C. diff because of the antibiotics, we were never going to get away without surgery. But yeah, it's a slightly suboptimal case from that point of view. So I've rather whistled through that, but hopefully that gives you a bit of time to think of some questions. So my take-home messages would be that not all symptoms in patients with diverticuli or diverticulosis are diverticulitis. Trying to get patients' stools regular, soft, but bulky, so they've got a decent stool for the bowel to push against is likely to help any symptoms and also likely to prevent complications from their diverticular disease. And if you want help or a second opinion, just want to run it by someone, go to someone, maybe me, maybe one of my colleagues, but go to someone who can offer you the full range of conservative and operative measures. Okay, there's a lot of progress happened recently, and there are good options out there, particularly me, of course. So have a think if there are any questions. I will leave my contact details up there for either the Nuffield or for the NHS for you to make a note of. And any questions either via the chat or feel free to jump in.
And don't be shy. Whilst you've got Mr. Ferguson here, please make use of him.
I'll take stunned silence as positive. I think it's a really difficult thing to how effective is fibre. I guess that's a how long is a piece of string question. That's a situation where everyone, almost to a person, could do with more fibre. It's really about getting that regular stool. So patients should be ideally opening their bowels once a day, once every other day, but soft, not straining. Obviously, my other sideline will be the interest in them not giving themselves piles or fissures and things like that. So, you know, how much fibre is enough fibre? How much fibre is too much fibre? It's very individual to the patient. So I don't think you can give an amount, but anything that the patient can do to improve roughage is going to help the situation. Should value be given to patients like a statin? So no. Is there actually that much benefit that the statin's good for you? Should you put it in the water? I think really it's that's in the realms of public health, really, isn't it? I think I think we're in a difficult situation in the UK with all ultra processed food and obviously the struggles that patients have with the cost of living and things at the moment. It's always much easier to grab something easy or processed, but the emphasis really just has to be on having a nice rounded diet. Going back to, there's a CT or MRI question. So in terms of investigating the colon, CT is much better. The resolution you get from the colon, because it's sort of around the outside of the abdomen. I'm not a radiologist, but MRI works better where you're focusing it in one area, so a knee or the biliary tracts for an MRCP. But if you're trying to image round the outside of the abdomen on a colon, they just don't get the resolution that you'd get with a CT scan. So I'd always go for CT. For small bowel Crohn's, something like that, I'd be much more likely to go for an MRI. Thank you. How long would you expect an acute flare to last? Yes, it very much can be, and it can be really hard to avoid giving antibiotics when there's a lot of pain. Bleeding and pain's a difficult one. If you think about how diverticulitis or symptomatic diverticular disease happens, bleeding often isn't diverticulitis. It's an erosion, and an erosion next to the edge, to the neck of the diverticulum where the perforating blood vessel comes in. So giving them antibiotics because they're bleeding wouldn't necessarily be particularly helpful. How do you avoid giving antibiotics? It's really difficult. We're rubbish at it. We're rubbish at it because even in hospital, we see these patients and, you know, trying to tell them that they've got an inflamed colon, but that you're just going to give them painkillers just doesn't cut it, does it? But I think it's, unless they've got peritonism, unless they've got obvious clinical symptoms, it would be, you know, clinical signs that they have diverticulitis, it would be reasonable to trial anti-inflammatory medications, painkillers, a bit of bowel rest, and see how they go. Obviously, if they've got temperatures and things, I don't think you've got any option but to give them antibiotics. But obviously, with antibiotic governance, you just got to be careful, and you've got to be careful with giving broad spectrum. Unfortunately, the best antibiotics for diverticulitis are often things like coamoxiclav or ciprofloxacin and metronidazole if people are penicillin allergic, which are the worst ones for giving people C. diff. So trying to be sparing in that way is probably the best way, just to moderate people's use. But yeah, I agree, extremely difficult. I've been told, I've had a patient who said she was told to never eat the skin of fruits or grapes. Gosh, yes, very much. I would say that the skins of grapes and things are actually excellent things. That is your fibre. That's your insoluble fibre that will give your stool bulk. I would agree that, you know, while the bowel is active and painful, then probably cutting down on that sort of thing would be sensible. But no, I would be advocating, you know, whole fruits and things like that. How many flares would you count as recurrent and need referral? Again, probably patient patient dependent. So it all boils down to activities of daily living and evidence of complications, really, I guess. So you can have patients who cope very poorly with even 1 or 2 episodes. You can have people who, men often will sit on symptoms forever and turn up with really quite bad symptoms. So I don't think you can say there's a specific number that would warrant referral, but if a patient's taken the trouble to consult you about it and is becoming concerned and don't respond to conservative measures, that would be a reasonable time to refer. I obviously you would see a lot more patients than I would with this complaint, I suspect, throughout the week. Or maybe not, because I see the specialist ones, but you know what I mean. You'll see a lot of patients with a lot of bowel symptoms, and trying to pick the ones which genuinely require secondary care, I guess, is related to how much it's affecting them and how likely you think they are to require secondary care input. So how likely you think they are going to require either more specialist advice than what you can offer, or indeed an operation. So we'll never say no, put it that way, for a referral. If you're struggling, I'll never say no.
Does anyone have any more questions? If you do, please type away or take yourself off mute. But what I will say is thank you ever so much for joining the meeting. And thank you, Mr. Ferguson. Is that another question there?
It is, yeah. How long?
Right, I'll stop talking.
No, that's okay. That's okay. I guess that's a difficult question. How long would you advise them to say to wait and see? So I guess that depends on the patient already knowing that they've got diverticulitis. So if you've got a patient who gets recurrent diverticular symptoms, it would seem reasonable for 48 to 72 hours of symptoms, providing they're not getting temperatures, rigors, becoming unwell, would seem reasonable before taking I don't know what your policy is on giving them just in case antibiotics. I know that some practices do. Some of my colleagues do. I don't like it because I think people overuse antibiotics. But I think 48 to 72 hours of symptoms, and if there's a clear trajectory that they're getting worse, then I think you're probably duty bound to either refer or to give some antibiotics and try. I think if someone hasn't settled down within, again, another 48 to 72 hours, having given them oral antibiotics, I think you've got to have a concern that there might be something a bit more complicated going on than just simple diverticulitis. And again, we'd be very happy to see those patients. Thank you.
Right, I will go back to my thank you very much for the talk, Mr. Ferguson, and thank you all for joining us this evening. We will send out your CPD certificates, a link to the recording, and also the slides. So thank you ever so much, and we will keep you posted about the next lectures.
Yep, you'll see me again, I'm sure.
I mean, other consultants, we've got to let them have a go as well.
Why would I do that? It's a nice way to spend your evening.
Thank you ever so much, everyone, and have a good rest of the evening.
Bye.
Bye-bye.